Okay, so I think we can start. So thanks for being here. As you may know, I'm Mariangela Pellegrini, so I'm happy to welcome all of you at this webinar organized by the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. As you know, this session is part of a cycle of webinar 11, precisely, that tackles topics that have been selected by the patients community and people living with sickle cell disease, so patients and caregiver, who selected 11 topics that are addressed each topic with one webinar. So today we are going to talk about sickle cell disease and pregnancy, gestational risks. Before arriving to today's session, I want to share with you some house rules. So as you can see, this session is recorded because we are going to implement the webinar on our YouTube and e-learning platform. So if you don't feel comfortable with that, you can change your name in the Zoom or you can switch off your camera. At the same time, after the presentation, there will be a session dedicated to questions. And you have both modality to exchange with the expert of today's lecture. So one is writing the question in the chat. And the second is unmuting yourself and raising orally question, comment, feedback, what you prefer. But during the presentation, your microphone will be muted. After that, you will have the possibility to unmute. So we arrived to today's session. As I said already, we are going to talk about pregnancy, and the lecture is led by Dr. Joseph, who is an hematologist in the PHP Necker Hospital in Paris since 2015. She's on the team of Professor Marina Cavazzano. She's specialized, of course, in sickle cell disease, and she's in charge of pregnancy sickle cell disease women at her hospital, with a reference center for this specificity. In addition, she's also involved in bone marrow transplantation and gene therapy clinical trials for sickle cell disease. So please, Dr. Joseph, the floor is yours. Thank you very much.
Thank you very much, Mariangela. It's a pleasure to be here today. So I will talk about sickle cell disease and pregnancy. My presentation is really short to encourage discussion after this presentation. And I hope we could talk about your experience and my experience after. So just to introduce, as you know, sickle cell disease worsens pregnancy, and pregnancy can worsen sickle cell disease also. Sickle cell disease is, as you know, an anemic hemolytic anemia, with which lead to vaso-occlusive events, with sometimes and often chronic inflammations, and many vaso-occlusive events during life induced lead to functional asplenia, with some infectious problem, especially during pregnancy. There is also a higher thrombosis risk, and all of this induce organic damages during life. With pregnancy, as you know, there is some hormonal secretion, with estrogen secretion in particular, and with rapidly during pregnancy, since first trimester, we observe increased cardiac output. There is a leukocytosis and hemodilution with increased anemia, and higher thrombosis risk with this hormonal modification. All of these factors induce sensibility to infection, which is a very important problem during pregnancy in sickle cell disease patients. During second and third trimester, we observe reduced lung volumes with need to some exercise during pregnancy to reduce these side effects. And all of this complication induced by sickle cell disease and pregnancy can induce fetal placental hypoxia and complication during this period. I just want to introduce this subject with our experience in France. We report recently our experience between 2013 and 2019. And with this registry, we report 1,270 sickle cell disease, pregnancy sickle cell disease patients. It is a very big register. And unfortunately, there is no code for genotype, but we separated sickle cell disease into two groups to analyze the different complications in patients with severe sickle cell disease. We defined this group with a prescription of hydroxyurea or transfusion program in year preceding pregnancy, and the other with no treatment. We define as mild SCD, and we think there are most of SC genotype or other genotype in mild sickle cell disease compared to severe with most SS genotype. This register including overseas departments. Here is just to introduce the subject, the population characteristics. It is known that in sickle cell disease patients become pregnancy younger than the French population, and we confirm this information. There was less diabetes history in sickle cell disease patients compared to French population, but more hypertension history. So we must be aware about this complication to treat this during pregnancy. HIV history is also most frequent, and it is very interesting. There is a very interesting information because we found that use of assisted medical procreation is less frequent in SCD patients compared to French population. This information, I think it's very important because sometimes women with sickle cell disease thinks it will be difficult to become pregnant, but it's frequently it's not a problem for these patients. So the key points of this study is that even good management, I think, of this population, there were more obstetrics complications in sickle cell disease versus French population, even in mild SCD compared to control. So even in mild patients, we must be careful during pregnancy. And there is increased risk of preeclampsia in severe sickle cell disease with very higher risk, around 11%. I think it's very important to talk about this because in France, we not prescribe for every patient aspirin, but I think this study can change the management. In mild pregnancy, the risk of preeclampsia is less frequent, but still significant, around 5%. Majority of patients have cesarean delivery, around 60% in severe SCD, compared to 35% in mild, but it's still more frequent compared to control, to French populations. We observed more maternal complication in sickle cell disease, especially genitourinary infection, venous thromboembolisms, and pulmonary embolisms. especially in severe SCD. That's it is important to talk about this because we need to prevent this complication during pregnancy with some prescription. We observe very important risk of preterm newborns, but you could see after that the risk is for not severe prematurity, but just for minimal prematurity because of medical reason, because sickle cell disease during pregnancy could have preeclampsia or could have infection, and sometimes a woman experiment many vaso-occlusive crises. So we prefer to give birth to the baby to decrease the complication for the woman and the baby. So sometimes between 34 weeks of amenorrhea and 36 weeks of amenorrhea, we perform cesarean delivery to stop pregnancy and stop complication. But the newborn is really well during this term. So here is the distribution of full-term and preterm newborn. As you can see, the French population is very different to compare if we compare to sickle cell disease population, but the difference is more important for severe SCD patients with with a majority of patients who are full term, but many during between 33 or 37 weeks of pregnancy, 37%, you can see here. For mild SCD is less important, but it's still more important compared to French population. But what about transfusion? It's a question for many sickle cell disease patients. The transfusion is not necessity during pregnancy, but sometimes we need to perform transfusion to decrease the complication for the newborn and for the woman. In France, we change the prescription. We decrease the prescription of transfusion because of alloimmunization risk during pregnancy. So we prescribe regular transfusion only for severe sickle cell disease women who have hydroxyurea before pregnancy, or for patients with many complications, as for example organic damages and so on. So you could see here that it's not the majority of patients that we transfuse, but 1/3 of patients actually in France and in overseas departments. Here is key points of management of pregnant SCD women. I think it's very important to precise that the follow-up of pregnant SCD women begin before pregnancy. If it's possible, I perform a preconception consultation to prepare the pregnancy and to prescribe an electrophoresis for the future dad of this newborn. And after, during pregnancy, it's very important to have a monthly medical and obstetric consultation since 2nd and 3rd trimester. After pregnancy, it is very important to continue this particular follow-up with a first consultation during after the 6 weeks of after delivery, and at 3 months and 6 months. It is not an obligation, but I think it's very good to help sickle cell disease women to reassure she will be a very good mother, and to help her if it's need with some medication and sometimes transfusion, or some advice about breast food and so on. So in conclusion, pregnancy is possible for sickle cell disease patients. I think it's a most important information today, but instead improvement in care, there is still significant maternal fetal risk for sickle cell disease women. So we have to improve this management to decrease this significant maternal and fetal risk. And I think it is very important to precise that for all sickle cell disease pregnancy, we need a specific multidisciplinary management. It's not only medical and obstetrics. It's anesthetist management, a specific anesthetist management. It's very important to prepare cesarean and birth of the baby and the postpartum period, with sometimes some vaso-occlusive events. And we need to inform blood bank to prepare eventual complication during pregnancy or during labor. Thank you for your attention. I'm waiting of your question.
Thank you very much, Dr. Joseph, for this comprehensive and very clear presentation. So as said before, we encourage the participant to ask questions related to pregnancy and sickle cell disease. So I will I'm doing it at the same time, so sorry. I will let you the possibility to unmute yourself and take the floor if you wish, or you can also write in the chat your questions. I can start with the first one because we had the occasion with Dr. Joseph to talk again about pregnancy during the ASCAT meeting, the session for patients. And I remember I was very impressed discovering and hearing about the testimonies of patients that were told when they were young that they will go through very highly risk pregnancy. And of course, this is a shocking notice to be heard by a young woman. So I would like to ask you if today we have the same approach to patients, and if I mean, when you have the contact with patient, how you approach this topic of risks in pregnancy, at which age you introduce it usually, and how it is now the situation, because of course the testimony I'm reporting were referred by adult patients, so it were referred to different guidelines, I think, and clinical knowledge. Thank you very much.
So thank you for this question. So I think this many things changed recently for sickle cell disease patients, and I think that this sort of explanation during life is not the same today for young patients. So I try to talk with girls when they come to adults departments. I talk with her very early in the management to introduce the transmission of the disease first, and to introduce, I think it's another question of the chat, the preventing unwanted pregnancies, because I think contraception is not really a discussion for pediatrics physician, and very often my patients are not really aware about this medication and possibilities in sickle cell disease in particular. So I'll talk about this, and after, if I prefer to let the patients begin to discuss about pregnancy, and very, very often girls ask questions about their possibility to being a mother in the future. So I try to reassure her, because it's possible, but I talk about the specificity of this pregnancy with some risk, but with possibility to reduce the risk with a very good management in a department, in an hospital who knows many things about this disease. I try to explain them, and I sometimes some patient ask me a very curious question, like today, just this afternoon, a young patient talked to me about cryopreservation of ovarian for her, because she thinks she was infertile. I was really surprised, because she has no specific problem, especially gynecologic or problem, but she thinks because of hydroxyurea and sickle cell disease, she will be sterile in a few years. So she wants to prevent this with cryopreservation. So I was really surprised, and I explained it was not the case, but she's really young. She's only 19 years old. So it's very curious. I don't know if it was an idea of his family, or if she read something in internet. But you're right. I think it's very important to talk about this opportunity during life with sickle cell disease patient, because sometimes there are wrong idea, fake news, I think, in this population. So I think it's my management, and I talk about this question very early with patients, with women patients, but I don't know if it's the case of my colleague, because my specificity is pregnancy, so it's my topic. So I want to talk about this with patients.
Yes, you deal already with adult patients, so it's more a topic for transition, I guess, for not for pediatric, but for transition. There is another question. You have already a little bit answer or comprehensive answer. I will read it just in case you want to add something, but I think you addressed this question. Thank you for this excellent presentation. What kind of sex education is there for sickle cell disease patients before they actually form a family and think about having a baby, thinking of preventing unwanted pregnancy and raising awareness on the importance of planning and adequate care? Well,
I can add that in my hospital, I'm very lucky because there is a specific department for transition called la suite. It's in French.
The following.
And in this department, there is young physician obstetrics who take care of very young adults between 15 and 25 years old. And for the first consultation for the first gynecologic consultation, it is very reassuring for my patients to stay in Necker Hospital and to be managed by a specific gynecologist. I think I'm really lucky for that. And many young women SCD patients had a consultation in this department just during or after transition to talk about contraception and sexual infection. And I think it's a very, very good idea of some pediatrics physician, and this idea will be extend to other hospitals, because I think it's a very, very reassuring for young women to come for the first gynecologic consultation in the same hospital than pediatrics.
Okay.
I'm not sure it's clear.
Yes, I mean, at least for me. Then, of course, from the audience, you can all write or unmuting yourself for asking for clarification, or any comments is always welcome.
For boy, it's different. I see the question. For
yes,
boy,
is there anything for boys with sickle cell disease? True, they also play a part in it. Congrats for your initiative.
For boys, it's different. There is no specific consultation, unfortunately, but I think during transition, we talk a lot about priapism, but it's not the positive. It's a complication specific for boys, but it's not linked to paternity. But I talk about paternity to boys, I think, later compared to women. I don't know why, because I have the impression that women are more mature compared to boys, but I think I may improve my management to talk with them earlier during transition. I think it's a good idea to organize a specific management for them too.
Thank you. So I've seen Vidifaeya, you raised your hand. You can take the floor if you want. You need to unmute yourself first.
Hello, Marie-Angela. It's Anna van der Faye here. Sorry.
Okay, sorry. I've just read what is written. Sorry.
So I'm working as a pediatrician in Belgium, and I don't have a special transition unit. But when the patients are arriving at transition, indeed, we send them to the city planning unit, which is an adult unit, but they talk about contraception, of course, and they prescribe special contraception for sickle cell patients. And they also talk about SOAS, of course. For boys, I had a guy, indeed, he was some years older, who had fertility problems. And he was sent to the urologist to organize a spermogram, of course. But before we start Hydrea in adolescent boys, we try to have also a sperm donation to do cryopreservations to prevent Hydrea effect on the sperm. So as a pediatrician, we are taking care of that. I can confirm.
Yes, we talk about effect of hydroxyurea too. I don't precise this, and yeah, we perform cryopreservation, and it's different. I think it's now hydroxyurea is introduced during pediatrics time. So we talk about the possibility to stop hydroxyurea to become and we discuss about possibility of a switch with transfusion if it's need. But if I'm totally honest, I think I talk about this when these people, these boys, talk to me that they want to be further, and after we talk about this. But I think I will talk more about this now.
Mhm. I still have ask you a question. What about oxygen administration during pregnancy?
We don't prescribe systematically oxygen during pregnancy because we perform a clinical trial here in Necker, but the result is not still published. And we don't find a positive effect of oxygen during pregnancy, but sometimes I observe some benefic effects in some patients. So I try this therapeutics in some pregnant SCD patients when the transfusion is not possible because of alloimmunization, for example, or if this woman present vaso-occlusive events, even the regular transfusion. But it's only it's not systematically prescribed for in our center.
Thank you very much. And I have also, if there are no questions yet from the audience, I would like also to talk about, so I don't know if it is correct in English, pre-implantation and prenatal diagnosis. So I would like to know if you handle this kind of cases in your pregnancy referral center, and if you can share with us some example or some comments on your feedback on those two topics.
Yes, we propose prenatal diagnosis if there is a risk for the baby to be to have sickle cell disease. We propose to all women with risk, but I observe that it's not always accepted for patient because sometimes they don't want to know, or sometimes they prefer to wait birth to have this information. With this proposition, we propose a genetic consultation to give all information about risk for the newborn. And this consultation, it's not done in our center, but in another center, Henri Mondor, as I think everybody knows this hospital. And if the parents want to do prenatal diagnosis, we do this in Necker Hospital after. For pre-inflammatory implantation, for pre-implant, I don't know the name in English, but when the woman have already had a baby with sickle cell disease and want another pregnancy, but want to be sure it will be not a baby with sickle cell disease, we propose pre-inflammatory diagnosis, but that take times around 2 years to do this this management. So it's very long for parents, and in many cases parents finally don't do this management and have a natural pregnancy. It's not good, but it's due to the very big delay for this management in France. I don't know if it's the case in Belgium, but in France, it's a very big problem to organize a pre-implantation diagnosis.
Thank you very much for this answer. So is the result the previous one or is a new one? Sorry.
Sorry, if I can
yes.
interfere.
Sure, please. I didn't know if it was the previously or, but sure, more than welcome.
For the pre-implantation diagnosis. So in Belgium, the delay is shorter, luckily, because we have several centers where we can send our patients. I'm working in Saint-Pierre, and already I can send my patients to Erasmus and UZ Brussels, and I'm not aware of the other centers in Flanders nor in Wallonia, but already in Brussels I have 2 centers where I can do my pre-implantation diagnosis. And then we have a specificity in Belgium, which we can't do in France. In Belgium, we can do pre-implantation diagnosis to prevent the birth of a sickle cell patient, SS or SC. But we also can add the detection of the HLA identity. And so we can select, we have the chance to select a non-sickle cell baby with the good bone marrow to be a future donor for the sick patients. I know in France it's not allowed to do those techniques.
Yes, it's not allowed. Yes.
Yeah, but in Belgium we have the chance to be able to do that. And if we do so, or if the parents want to do so, this takes 6 months time to prepare. So compared to your 2 years, it's incredible. We only need 6 months because the sickle cell pre-implantation diagnosis is a technique which is ready. It's always the same mutation we need to look. So there is no preparation needed. So I don't understand very well where the more than a year comes from.
It's not specific to sickle cell disease. It's specific to assisted procreation in France with delay for everybody, especially for pre-implantation diagnosis.
Okay, that's a pity.
Yes.
Thank you so much. So we'll see if another question pop up. I think we have already seen all the aspects linked to pregnancy, but please do not hesitate to comment or ask questions or share an experience if you want. Okay, I think everything has been addressed. So I would like to really thank again Dr. Joseph to be with us and share your expertise and your time with us. And of course also to the audience for the great debate we had. And I wish to all of you a great afternoon, and I hope to see you on the next session. That will be on, I don't remember by heart, so I'm thinking. It will be the 4th of July on sickle cell disease and immune disease. We also have an expert from APHP Necker Hospital. So the speaker will be Slimane Alali, hoping to pronounce it properly. And so thanks to everybody, thanks to Dr. Joseph, and wishing you a great afternoon.
Thank you very much. Bye, everybody.
Bye-bye. Bye-bye.